Welcome to As of 2020 in Trieste. We are gathered here, I would say, from remote and also on site to discuss about a very important topic, both in research and for the social issues raised by this topic. The topic is the ethical and usefulness, the ethical impact and the usefulness and effectiveness of screening tests in children in a cross-border setting. I would say the most important topic for future research in genetics. Screening test, as you probably know, is an exam that can identify an unrecognized result, but genetic testing, especially in children, bring with them many questions about the future of those children and also the need to perform such exams, and it is particularly important to discuss those issues in a cross-border setting. That means taking into account different, I would say, different sensitivities, different cultural approaches, different values in different countries. That's why ACE of 2020 is now hosting this event that will be introduced, first of all, by Dr. Alberto Tommasini from the Maternal and Child Health Institute Burlo, Garofolo in Trieste. Dr. Tommasini will start introducing the general overview of this topic and why it is particularly important to discuss with the general public and not only with specialists the topic of newborn screening. Professor Tommasini, there is a mistake in the slides according to the to our order. Professor Tommasini should be the first one to speak.
Okay, thank you. Good morning. Can we present the slide? Okay. This conference is built on in the context of in the context of this project that is a collaborative project between Italy and Slovenia called Cattedra, coordinated by Professor Taddeo, and aimed to foster the care, the diagnosis and care for children with a complex disease in a cross-border setting. And we are witnessing great advances in science, technology, and healthcare, but it is not easy to reflect this in the practice of clinics, as we have to take into account several factors which are ethical, economical, and practical, and that are different in different countries. Let's start from these four movies poster. They are all about genetic disorders. The first is Morquio syndrome, that is a metabolic disease due to the accumulation of macromolecules in organs with organs damage. Adenoleukodystrophy is a progressive neurodevelopmental disorder. Osteogenesis imperfecta is a disorder characterized by brittle bones and dwarfism. And severe immunodeficiency are a group of disorders in which the immune system is lacking or is not functioning properly, and patients can have severe infection from normal germs and can even die because of them. These movies focus on different aspects, on various aspects of dealing with a genetic disease. The first one is about the friendship between two children with genetic disorders, complex genetic disorders. The second one focuses on the commitment of parents to find a cure for this severe lethal neglected disorder, even if the Lorenz's oil, the cure that they found, is more based on hopes than on evidence. And the third is the autobiography of Kanga, and the movie is starred by the patient himself. It focuses on the sexuality problems for people with genetic disorders, with complex disabilities, and in this case also with the particular gender orientation of the men conflicting with the parents' attitudes. The last is about a story of some decades ago of a boy who was born in a plastic cage, in a plastic isolator to prevent infection, as he had no immune system, and he had to live in this isolator. But let's start from a particular genetic disorder that had a crucial role in shaping the scientific and social knowledge on genetic disorders in the 20th century. It is phenylketonuria. This metabolic disease due to an enzyme deficiency and the accumulation of phenylalanine in brain with brain damage and mental retardation. This article that I'm presenting, issued on Lancet in 1951, was a milestone in the history of genetic disorders, as it showed that it was possible to prevent the accumulation of the toxic amino acid with a particular diet. Just 10 years later, the newspaper came out with the news of children in whom the diagnosis could be made at birth, and in whom the evolution toward mental retardation could be prevented by this mind-saving diet. This story is well described in a book of the series of the Johns Hopkins biographies of disease. Let's just follow this story together with the story of Carol, who was a girl born in 1920. 1920 was a period in which genetic disorder was seen as something wrong in a family, as a kind of regression to a previous step in human evolution. And there was a stigma for families, as mental retardation was associated with aberrant behaviors, and the family, all the family of these children was seen as something wrong. Carol had phenylketonuria and developed mental retardation, but in the years after his birth, it was discovered that the phenylketonuria is a metabolic disease, that the cause of mental retardation is the accumulation of a substance because of enzyme deficiency. And this was an argument important also to contrast the theories of eugenics, discovering in the article I saw you in the previous slide, discovering that mental retardation could be prevented in genetic disorders was really a revolutionary discovery. And the mother of Carol in 1950 published this book, The Child Who Never Grew. It was a very important step in the history of genetic disorders, as it just told the history of the daughter of the writer, but it gave back the dignity to families. And in fact, National Association for Retarded Children got strength to ask for screening and to obtain screening, the first screening for a genetic disease that could be cured if identified at the birth. After, in some years, we will have screening for an expanded newborn screening for several disorders. Thus, we have newborn screening for phenylketonuria, many other diseases, and in these recent years, also it has been proposed for primary immune deficiencies. The screening of neonates, of newborns, is important if we have a cure. But in other cases, without a cure, in families where there was a child with a severe fatal disorder, another option can be the identification in utero during pregnancy and the interruption of pregnancy or abortion. A third option is, before to get pregnant, the identify the carrier of the disease and offer the possibility to in vitro fertilization, pre-implantation diagnostic. This could be an option for particular disorders that are most severe and less rare, as cystic fibrosis, maybe spinal muscular atrophy. Just 3 cases to highlight how the history of disease is accompanied, is paralleled by the history of patient. It all depends when you born and where you born. This is a family with a history of severe combined immune deficiency in the first boy. The second boy, they refused abortion, and doctors gave them the option to make the next boy born in an isolator, in a plastic sterile isolator, until a cure could be found. And we can see the timeline of primary immune deficiency together with the death of Davids. And just 3 years before, a boy with the same disorder was treated successfully by bone marrow transplantation from his compatible brother. Unfortunately, David's sister was not compatible, and then he had to stay several years in the plastic isolator. It caused various concern in people or in physicians. It was very difficult for him, as he had to balance the fear for infection, the fear for germs that was inculcated in him to prevent his escape from the cage, with the hope for freedom, for living in his family. The NASA produced for him a space suit coat to allow exiting from his plastic bubble, but he just once used it, as it was useless as a perspective. When he was 12 years, he received the bone marrow transplantation from his sister, but unfortunately he died because of a complication of transplantation. A lymphoma occurred because of a virus in cells from the sister. Some years after this, the life of Davids, a pivotal, very important, crucial discovery occurred in the story of immunodeficiency. That is the finding that in some cases a somatic reversion, that is a mutation that corrects the previous mutation and make the right sequence of DNA, can be amplified as the cells that have the correct sequence are have a fitness, a positive fitness compared to other ones. And this was the real proof of concept that gene therapy was feasible, and it was indeed proposed and realized in IRCCS some years afterwards. Another important advance in the history of primary membrane deficiency is the possibility to make a screening by measuring the track that are a particular DNA test on the Gatris card, on the spot of blood that is obtained by newborns. But today we'll discuss about this. The second case is about a boy with spinal muscular atrophy. Alessandro Amadeo will explain in more detail what is this disease. It is a very, very severe disease where muscle does not function properly. You can see this boy very weak, and the failure of muscle can produce failure of respiration or alimentation and so on. This is the history, the timeline of significant advances in the knowledge on spinal muscular atrophy. And what was most significant was the identification of the first, the gene, SMN, but more interesting, the identification that it has a paralog, a very similar gene that can mitigate the disease and then can be responsible for cases less severe. But even most interesting was that it was possible to produce a drug, a medication that improved the ability of the gene SMN2 to make a good protein. When William, that was our patient, was born, there was no such possibility. But when he was just 1 year old, this possibility was available. The drug name is nusinersen. The family had already accepted that they would lost their boy, and they renounced to therapeutic obstinacy. But when they know about this drug, they decided to give it a try, just for 3 months, as William did not have any benefit from this drug, and they came back to the initial decision. The third history is about an actor. Maybe some of you know him. It is Anton Yelchin, an actor that is famous for his part in Chekhov, in the remake of Star Trek as Dr. Chekhov. He was affected by cystic fibrosis. He was born in 1989. In 1989, his cohort of patients with cystic fibrosis began to have a significant improvement in survival compared with the previous cohort. This improvement were due to a number of small advances that you can see in this slide. The production of acid-resistant pancreatic enzymes to improve digestion, the production of recombinant DNase to digest the bacterial and neutrophil DNA in lungs, the inhaled tobramycin, azithromycin, the hypertonic saline, and eventually several drugs that can potentiate and in part correct the genetic defect, making the protein, the chloride channel that is defective, make it more functional. What is very sad and strange is that Anton could keep hidden his disease during his career, completely hidden. This was maybe necessary for him to have the opportunities of his career. And what is said is that he died of suffocation, but not suffocation because of lung disease, suffocation because a freak accident of his car that hit him against a wall. Urosh will speak about cystic fibrosis. All these stories are intended to tell that we have always to pay attention on how scientific innovation and new medication, new technological possibilities can impact on the life of patients. As there are surely several improvements, but there may be important costs and troubles that have to be well considered. Thank you very much.
Thank you very much, Dr. Tomasini. As we saw many cases in your presentation. But what we immediately catch is that there are some life-threatening conditions like primary immunodeficiency disease that do not have at that moment national newborn screening tests, and in some circumstances those screening tests, when available, are not fully useful. So, and this is the case of many genetic diseases that do not have a treatment available or have a high rate of mortality during childhood. So for these conditions, there is a debate about the usefulness of other kind of screenings like the carrier screening, the screening of the potential mother or potential father, depending from the genetic diseases. And I think that primary immunodeficiency diseases are a good example, but other diseases like spinal muscular atrophy also involves a consideration about what we can do once we have the prenatal diagnosis or the children diagnosis. And so I will give now the floor to virtually to Dr. Alessandro Amadeo from Hôpital Necker-Enfants Malades in Paris. I think, Dr. Amadeo, you will help us to understand something more about about the case of spinal muscular atrophy.
Yes, of course.
Thank you.
Thank you very much to everybody. Thank you very much for this invitation. Actually, yes, I will speak about the case of SMA, spinal muscular atrophy, which is, as you said, one example of how a major breakthrough in treatments has led to a change in our view of how to treat these infants, and also a change in our view on how to do screening tests. And it's actually one of my favorite topics, because actually it's clearly linked to my starting career in pediatric, as you will see. So we are speaking about actually spinal muscular atrophy, which is an autosomal recessive disorder, meaning that it's a genetical disorder of non-sexual chromosome, and you have to have actually a recessive means that you have to actually that your two parents being a carrier of mutation. It's actually one of the most frequent causes of recessive autosomal severe disease, because 1 in 6,000 or 10,000 newborns has this disease, and the carrier frequencies is approximately 1 to 40, 1 to 60, meaning that 1 in 30 people have a mutation. And it's actually nowadays the leading cause of infant mortality among autosomal recessive disorders. As Alberto said, actually, we now know that we have this gene, which is SMN1, which arrests apoptosis of motor neuroblast, which is linked to the production of a full functional protein. And also, we know that we have a second gene, which is SMN2, which has a defect in splicing that produce produce the protein, but not in the good amount. So only 10% of this protein is produced and is functional, meaning that SMN2 is a protective gene. And so the more copies of SMN2 you have, the less severe is your phenotype. This is really important because starting from this point, we had the possibility to identify 4 types of disease, and I will concentrate my talk on the first one, the SMA and type 1, because this is the most severe that we have actually in our clinics. It's a disease when with age of onset of 6 months, 3 to 6 months, and it's leading to death in 50% of these children by the age of 1 year, and in 90% by the age of 2 years if nothing is done. And as Alberto said, since this is a neuromuscular disease and the result is muscle wasting and muscle weakness, we have mainly 2 main complications, which are chronic ventilatory respiratory insufficiency, which is clearly the leading cause of death in these children. And if we have to do something, we have to do chronic ventilatory support. And on the other hand, these children cannot eat well, so they have feeding difficulties. So they need to have enteral feeding via gastric tube or gastrostomy for all of their life. And I said earlier that it was my I am particularly touched by this disease because my first experience is about the first child I have seen as a patient was back in the summer of 2005, and I was doing a training period as a nurse, and one day, you know, it's summer, one day, not a busy one, interested, one of my colleagues asked me if I wanted to join him during his round. And I remember clearly entering this room with a 3-month-old child lying on the bed, really floppy, so he was really hypotonic, and the parents were waiting for SMA analysis, but the diagnosis seemed quite sure. And I clearly remember the mother asked the doctor, it was back in 2005, if it is SMA, what's next? How we are going to cure my child? And as a young doctor, as a young student, actually, I sat there and I listened to my colleague starting to delineate the 3 possibilities that at that time we had. So the first one, and here you see a survival estimation, a cure for estimation of survival for the 3 possibilities. So at that time, the natural course of a disease led to death in almost every child by the age of 2. And natural course doesn't mean that you do nothing. You do palliative care. You try to comfort the child, but meaning that you don't do anything to support the respiration of the child. It was that time that we started to develop non-invasive support ventilation, which was another possibility, and that led to a mortality rate of 50%, almost at 2 years old. And then, of course, we had at that time the possibility to do a tracheostomy and to start a ventilation support for all lifelong for this child, for these children. And this led to an improving survival. But at the very end, the mother had to choose between doing a tracheostomy and having an infant ventilated all day long for all of his life, not a child who could not ever moving, not ever sit properly, or having this mask on his nose, again, 24 hours a day for all of his life. And at that time, I clearly remember the mother said, okay, doctor, if it is, we are going to choose the natural course of the disease. We are going to comfort him, but we are not going to do any other treatment. And so if you had asked me at that time, it was 2005, what is your best idea how to start a screening for this disease? I think that I will have to say that at that time, I was clearly for carrier screening, meaning that I think that it was fair to say that we didn't have any cure, so we had to identify carriers and try to do genetic counseling and try to reduce the prevalence of the disease. And it was clearly the debate at that time, because this is a practice guideline of the American Academy of Medical Gynecology, 2008, and you see that SMA was proposed as carrier screening because it has all of the criteria, because it was clinically severe, the high frequency of carrier in the population. We had a test, which is, of course, the test we can use now, which was high specific and sensible, sorry. And we have the availability of doing it, and of course, the access to genetic counseling. And if I had to add one thing, we didn't have at that time an effective cure for this disease. Then something happened, because starting from the late 2000, we start to have some development in the research on this disease. So there were at that time at least 4 lines of research, and which were gene therapy, antisense oligonucleotides, and other drugs. And then something happened, because in 2015-16, as Alberto said, we had the opportunity to have the first result of nusinersen, which is an antisense oligonucleotide, meaning that it's a little a molecule that binds to SMN2 gene, enhancing the production of the good protein, because it alters the splicing, giving a more stable protein, which is clearly functional. And so by enhancing SMN2 gene production, transcription, and then protein production, we had the possibility to restore a certain level of SMN protein in these children. And the only thing is that at that time, this drug, it has to be delivered by intrathecal injections, so you have to do a lumbar puncture every time. So FDA approved the drug in 2016, and just to put it on the context, we are talking about revolutionary drugs that cost $650,000 for the first year of treatment, and then almost $400,000 every other years, versus which is something that we have to take into account when we are talking about what we are going to do with our children, versus 100,000 euros per year, which is the cost of illness for SMA type 1 patient in Europe. So FDA approved this in 2016, and soon after, there were a huge debate, because everyone wanted the drug, which is clearly something that we were expected it was expected, but even the people that approved the drug said that nusinersen appears to be a very marginal drug with a tiny effects, because it's clearly improved the muscular function of these children, because we had an increase in some motor milestones. So children were able to sit, for example, but they will never walk again. So we had to face the fact that we had a really a really expensive drug, which improved the motor milestones. But just to be to start from to clear the ground here, we had children were still on a wheelchair, still needed ventilation for almost all day. And at the very end, we didn't improve, we think that we didn't improve a lot the motor effects on these children, except that we started to think about how to change the natural course of the disease. And some data pop up at that time, and then this is a paper of 2019, and the results of this paper were about the treatment of pre-symptomatic infants, meaning that we started the treatment in children that did not have the disease yet. So, and we clearly see that this improve motor milestones in a better way, in a good way. So children were able to start walking alone. And so this raised the question of giving this drug to pre-symptomatic infants, meaning that this urged the question to start a newborn screening effort to catch these children before they are symptomatic, to start the treatment before they start to develop neuromuscular symptoms. And then again, in 2017, but was almost the same years, gene therapy was developed for spinal muscular atrophy. This is the paper, the cornerstone paper published in the New England Journal of Medicine in 2017. They developed a viral vector, which clearly which insert a certain strain of DNA in the child DNA and replace the SMN defective gene. So they developed this drug, and the results were actually really good in terms of motor milestone. On the right part, you have the motor milestone of children treated with gene therapy, and you clearly see that there is a progression of motor milestone, meaning that the child starts to develop normal motor milestone. He started to sit, he started to walk, and this is clearly something that we didn't see in the natural course of a disease. So the drug works, but again, this drug is actually so far the world's most expensive medicine. So we are dealing with the fact that we have a drug of which costs $2 million, and we have the ethical, I think, obligation to start the treatment in our children. But again, as for nusinersen, our data showed that we have to start before symptoms began. So we have to start earlier, as early as possible, as soon as possible. Otherwise, it would be not a waste of money, but not as efficient as we want it to be. And just to add some other complication, this is the drug pipeline for SMA nowadays, and you can see that each of this line is a new drug that will be developed. It is developed now, and that will be in the market soon. And this means that at the very end, we will have a lot of drugs, and they will all cost a lot. And the problem will probably be the same. We'll have to give these drugs to the children before they start to have symptoms. So our community started to think about newborn screening, because if we have the drug, and if the drugs works actually, and if for it to work, we have to do it to treat children in pre-symptomatic period. We all have to start doing diagnosis before symptoms began. So in the US, actually, this is something that I found 2 weeks ago. In the US, they started last year a newborn screening test in some of the states of the US. You know, US is a huge, it's a puzzle in terms of health system. So nowadays in the US, if you are born in one of these cities, in one of these states, you have newborn screening also for SMA. And that's because we all want to start the treatment as soon as possible. And what about Europe? But it's news from yesterday, actually, that we are starting to have alliance to seek SMA newborn screening across Europe by 2025, meaning that we are going to start wondering about the cost effectiveness of this screening. But I think that probably in the discussion this will pop up, but we don't even have to think about it because the cost effectiveness of this is quite clear. And the whole thing we are going to speak about and to think about is the ethical issue that rises by the fact that we have to do a really homogeneous screening test all over Europe. We don't have to do a difference between some countries. So we have to start thinking about Europe and not only about our own country. And just to add another thing, in Italy, they started this as a pilot project study in Tuscany and Lazio. And we started this last year, and so far they already diagnosed 6 patients which benefit from gene therapy. And of course, general news state that they saved the children. I don't know if actually they saved them, but actually at the very end, they do the best they can, the best we can do it right now for these children. And so at the very end, the conclusion of my talk is that the decision to start the screening program should consider, of course, all that we saw. So the frequency of a disease, the severity of a disease, the availability of a simple screening test, and the availability of an effective screening treatment. Sorry. On the other hand, you have the cost of a screening program, the cost of a treatment versus the cost of illness, and the decision to reallocate resources, because we all know that we are really short in resources, and it is most important probably now, because with all the COVID pandemic, I think that deciding to allocate resources to a screening program nowadays, when we have problem in the ICU, not enough bed, it's a matter of concern. But I think that on the other hand, we had to look forward, and this is what we are going to discuss today. And of course, it all depends on your healthcare system organization. But again, I think that our aim will be to make the most uniform possible, the most homogeneous possible our health system across Europe. And of course, in all of this, the question is always, where do you put children and their families? When do you put their best interest for children and their families? So thanks from Paris to Trieste.
Thank you very much. Thank you very much, Dr. Amadeo, for your clear and inspiring talk. I think we now all understood that things are going on very fast. There are other diseases where treatments are not as effective breakthrough discoveries are not as available as for spinal muscular atrophy. Nonetheless, we are moving from the idea of screening the carriers to the idea of screening the newborns. This is the case of primary immunodeficiencies. So I would like to invite Dr. Tadej Javcin, Head of Allergy, Rheumatology and Clinical Immunology Department at the University Children's Hospital of the University Medical Center in Ljubljana, Slovenia, to introduce us to these diseases and what's going on and why we are changing our focus, our goal in this screening. The floor is yours, Dr. Javcin. Thank you.
Thank you very much for this nice introduction. Good morning to on-site and virtual digital participants. I would also like to thank the organizers of ESOF for giving our center the opportunity to present this topic. So, as it was emphasized, the topic of my presentation is newborn screening for primary immune deficiencies. This is the, okay, so now it's working. So this is the outline of my presentation. First, I would like to give a little bit of background on primary immune deficiencies. Then I will focus on newborn screening and focusing on effectiveness and usefulness of screening tests. And at the end, I would like to highlight some future perspectives for newborn screening in primary immune deficiencies and some ethical considerations that are open in this field. First, I would like to highlight that at the opposite to spinal muscular atrophy, primary immune deficiencies are a large heterogeneous group of inborn errors of protective immunity. Child or adult with primary immune deficiencies usually present with recurrent, severe, or unusual infections. Young children would have failure to thrive. Patients, approximately 30% of patients with PID present with autoimmune and inflammatory manifestations. Children might also present with characteristic syndromic features or some rare unusual malignancies. This slide shows that in the last 20-30 years, there was an explosive growth of knowledge in the field of PID. And you can see that nowadays we can actually recognize clinically, molecularly, genetic, and immunological more than 400 different primary immune deficiencies. Individually, each of these diseases is quite rare, but as a whole, the prevalence of primary immune deficiencies is much more common, between 1 to 5 in 1,000 persons. This is just an overview that you will see this heterogeneity of diseases. I will not go into details for classification, just to highlight that the most common are predominantly antibody deficiencies, but quite common are also combined T-cell and B-cell immune deficiencies and combined immune deficiencies with associated syndromic features. This slide shows that in the last 15 years, the rapid knowledge growth in the field of primary immune deficiencies. And I would like to highlight that particularly a subgroup of immune deficiencies with immune dysregulation, with autoinflammatory diseases and innate immune defects, there was a rapid development. In the next part of my presentation, I will focus a little bit more on severe combined immune deficiency, which is the most severe form of primary immune deficiency. Again, this is not a single disease, but it is a group of disorders, more than 20 genetic defects that cause severe combined deficiency. And the unique part in this group of diseases is that they have all genetic defect of T-cell development. They do not have mature T-cells, so they do not have functioning T-cells. And because functioning T-cells are important also for functioning of other hematopoietic cells, they have commonly also some associated defects in other cells like B cells and NK cells. Incidence data from newborn screening shows that this severe combined immune deficiency is present in 1 and up to 30,000 and 50,000 children. In Slovenia, the incidence for primary immune deficiency is slightly higher. We see approximately 1 child with severe combined immune deficiency every year. And our birth rate is approximately 20,000 live births per year. So there is considerable genetic heterogeneity of these patients. And I would just like to highlight this genetic heterogeneity, that genetic defects can be in functioning of thymic epithelial cell, which is presented here. The genetic defect can be in T-cell receptor signaling on the membrane of T cells. This defect can be in cytokine signaling, in post-receptor signaling, or this defect could be on the level of DNA, which I will show later is so important for gene recombination of T-cell receptor gene. We call this variable diversity joining recombination, VDJ recombination. Child with severe combined immune deficiency usually present early during life with failure to thrive, with some unusually severe infections. They can present also with severe autoimmune phenomena, and they frequently develop opportunistic infections, like infection with Pneumocystis jirovecii, cytomegalovirus, extensive candidiasis. This is one of our patients with severe combined immune deficiency who presented at the age of 6 months with severe hemolytic anemia and thrombocytopenia. So presented with autoimmune phenomena, but later developed CMV chorioretinitis, which is an opportunistic infection. This is an overview slide showing a treatment for primary immune deficiencies, and for severe combined immune deficiency, the most important is hematopoietic stem cell transplantation. For some of the SCID patients, also gene therapy, and for example, for those that have defective thymic epithelial cells, also thymic transplantation. So hematopoietic stem cell transplantation is a curative treatment for severe combined immune deficiencies, for large majority of severe combined immune deficiencies. I would like to highlight here that the outcome of this hematopoietic stem cell transplantation depends greatly upon the age at diagnosis and infectious status of the patient. And I will show you this on the next 2 slides. These are quite recent data showing that if the bone marrow transplantation is performed before child developed these severe infections, the survival rate is 95%. But if the patient had some previous active infection, the survival rate drops to 80%. And in the past, this rate was even lower. I will show you data also from another study that nicely presented how the age of a patient influenced the success and survival rate of bone marrow transplantation. You can see that patients who were transplanted at the age of less than 3.5 months, the survival rate was more than 90%. And the worst survival was for patients that were older than 3.5 months and had active infection at transplantation, where the survival rate was 50%. So this is the background of severe combined immune deficiency. Luckily, now we have screening test for severe combined immune deficiency, and the test, as was mentioned by Professor Tomasini, is called T-cell receptor excision circles, or TREX test. So just a brief introduction to this test. During the T-cell development, every T-cell needs to have gene rearrangement of the genes responsible for T-cell receptor. Because we have very variable T-cell receptors, this rearrangement and splicing of the DNA that is not useful for T-cell receptor, we have a large variability of these excision circles, which is kind of a exist DNA which is not useful for the development of T-cell receptor. And these tracks, these remnants of DNA, stay as a circular DNA. And this analysis of T-cell receptor excision circles can serve as a biomarker for the production of naive T cells. And we can count the number of these tracks in the blood. Tracks do not replicate in dividing cells, so they are direct markers of production in naive T cells. And they can be ideal surrogate markers of newborns' capability to produce T cells. The good thing is that these excision circles tracks could be tested on DNA extracted from a dried blood spot collected at the birth. So it's kind of a very easy to test these tracks. So principles of early disease detection by a newborn screening was already briefly mentioned for spinal muscular atrophy. This was originally proposed by Wilson and Younger in 1968. And you can see that also severe combined immune deficiency fulfills all the criteria. It's an important health problem. We have acceptable treatment, not only treatment that reduces morbidity, but still it is the first condition that can be actually cured lifelong by bone marrow transplantation as a result of screening at birth. And of course, we have facilities for diagnosis. The test is acceptable, and actually there is an ongoing development and policy for this testing. I would like to show the data for newborn screening for severe combined immune deficiencies in different parts worldwide. United States in this respect was kind of leading the field. They started in Wisconsin in 2008 and then spread all over United States. So United States for the last few years are screening for SCID in every state. And there are several countries that started with pilot projects and some countries that have kind of a nationwide screening. In Canada, there is Ontario as a province. Norway, Sweden, and Israel are screening as a whole countries. There are also pilot projects in UK, in Spain, in Catalonia, and also in Slovenia, we performed a smaller pilot study for the Ljubljana area and for patients that were already diagnosed with PID. The data for US showed that actually these are years of diagnosis. So you can see here the years, and there is an increasing percentage of patients with severe combined immune deficiency that are diagnosed by national newborn screening tests. And the number of patients that are recognized by kind of presenting by infection is rapidly dropping in United States. For Europe, unfortunately, this is not the case yet. I will show you also some results for national newborn screening for SCID in California. These are data from 2019. They already screened more than 3 million patients, and they identified 213 infants with T-cell lymphopenia. They kind of estimate that T-cell lymphopenia is present 1 in approximately 15,000 births. And out of these 213 infants, they were able to identify 50 cases of SCID, and prompt treatment in these patients led to 94 survival, which are excellent numbers that were unimaginable, let's say 10 or 20 years ago. This national newborn screening with tracks do not identify also SCID patients. They identify all conditions that cause T-cell lymphopenia. So in addition to SCID, they identify also DiGeorge syndrome, some genetic syndromes like trisomy 21, Down syndrome, some secondary causes of T-cell lymphopenia, and in premature babies, because of underdevelopment of thymus, they also have T-cell lymphopenia. So in the next part of my presentation, I would like to somehow highlight some developments in European Union and some future perspectives. In European Union, the cooperation on newborn screening for rare diseases is still an underdeveloped area. So we have pilot, as I said, pilot developments in certain countries, but no kind of a unified call to action. And the title of this session is also cross-border collaboration. I would say, in addition to cross-border collaboration, we need also European-wide collaboration. And it was an initiative started by patient organizations like IPOPI screened for rare, together with members of European Parliament. And this call to action proposed to develop and implement overarching guidelines in the field of newborn screening for rare diseases, to develop a EU-wide platform on newborn screening, and to cooperate more close within Europe to share best practices. And I would highlight that this would be particularly helpful for some smaller European Union countries that have difficulties to establish wider newborn screening programs for some very rare genetic diseases. For future perspectives, I would like to highlight development on genomic sequencing for population screening. First studies are already popping up. The first was published in 2017, where they performed whole genome sequencing in a cohort of 1,349 newborn parents trios. So all newborns had a whole genome sequencing, and analysis was performed for 329 immunodeficiency-related genes in this whole genome sequencing data. They found 5 individuals that carried potentially pathogenic variant, but they also identified clinical asymptomatic individual with complement C9 deficiency, which usually is not kind of a life-threatening disease unless they develop some meningococcal infection. There is also availability of multiplexed proteomic screening for primary immune deficiencies, so the wide analysis of defective proteins. With this large amount of data, there are additional ethical considerations for newborn screening of primary immune deficiencies, particularly questions about the ability of clinicians how to interpret, how to communicate this large amount of data. Because we do not have data, the effects of these mutations. There is a wide phenotypic variability in primary immune deficiencies that we have to take into account. So it's not just the genetic information, and we struggle to decide which information should be disclosed to parents and patients. And of course, there is always a question if the newborn screening is kind of a obligatory test. It is the question how this vast amount of information will be used in future research, how this will be used by governments. So this needs to be clarified. So I would like to conclude my presentation to highlight that newborn screening practices for primary immune deficiencies have evolved significantly and are still evolving. There is no single, because these are heterogeneous diseases, there are no single assay at present time that could identify all forms of PID. TREX are excellent screening tool for identification of severe combined immune deficiency, and we are already in the genomic area. So it is quite likely that newborn screening for primary immune deficiencies will involve upfront NGS testing, either whole exome or whole genome sequencing to identify these patients, which brings up several new ethical considerations. At the end, I would like to somehow thank all our PID immune deficiency team from our Children's Hospital in Slovenia. Professor Abinon was visiting physician, and hello at the end by our group of patients with primary immune deficiencies. Thank you very much.
Thank you very much, Dr. Ravchin, especially for highlighting what's happening all over Europe and the main ethical questions we should discuss. We already actually have questions from the floor, but we keep them for the end. We have around 25 minutes left, so I will ask all the people interested and the people following this conversation online to send their questions, so we collect them and try to answer in time. Now we are moving from primary immunodeficiencies to a disease that has a well-established screening procedure, which is the cystic fibrosis. I think this is a very important discussion to debate the ethical issues related to cystic fibrosis. First of all, because it's a disease that has that became, I would say, also famous in some way because of some pop culture products, like a very well-known movie called 5 Feet Apart. I have 2 teenagers, daughters, that read the book and watched the movie, and since then they follow on YouTube a couple of young patients describing their life with cystic fibrosis. Of course, this kind of public awareness changes totally also the perception of the disease and the ethical debate about the screening. So I will leave the floor now to Dr. Uro Skrivec, the head of Unit for Pulmonary Disease at the Pulmonology Department at University Children's Hospital in Ljubljana. He will talk about the effectiveness, usefulness, and ethical impact of screening tests in children in a cross-border setting, I think, especially starting from your experience with cystic fibrosis. The floor is yours. Thank you.
Good morning, everybody. I hope you hear me well.
Very well, thank you.
It's a great pleasure to be with you. It was a great pleasure to attend this meeting from the morning, because the talks that we heard are really inspiring, and they really open a lot of questions and debate. I will start with the presentation on cystic fibrosis, which can be a kind of a model of a multi-system and a rare disease. In fact, it's the most prevalent rare disease. It affects, in general, 1 in every 4,000 to 5,000 live birth infants. Of course, it's not the same throughout the whole Europe, and it's not the same throughout the whole continent, but still there is an important number of patients. Altogether in Europe, we have nowadays about 50 to almost 60,000 patients in the registry, and combined with the US and Canadian and Australian, it's over 100,000 patients that are in the registry all over the world. So it's a disease that, even though it's been rare, it's been studied for a lot of time, and it has a lot of very good data. It can also be taken as a model of a disease, because the approach of treatment have really moved through a lot of phases, and there has been a lot of energy and influence put into it. It's a very severe disease that affects primarily almost all organs of the body, but it affects the respiratory system and the gastrointestinal system at most, especially in small children. First of all, it affects the growth, because the children cannot get enough energy from the food, and pretty much in the same time, and the studies show even prenatally, these children have affected lungs because of ineffective clearance. So the lungs, and not only the lungs, but also the upper respiratory system, gets affected and chronically ill, which leads, in the natural course of the disease, to very severe problems very early in life. This disease was devastating in the very early years, let's say in the 30s, in the 40s. The estimated survival was really grim. But with all the energy that was put in the treatment of these children, the survival really rose a lot. And it was not due to some very, let's say, breakthrough genetic tests, but it was really put in place by very actual clinical examination and clinical appearance. And it's also a path or a storybook of how the clinical examination can really show that certain approaches that were thought to be the best show up to be really the wrong one, and how it is important to say, well, these were our data that we used them, but the real life is different, and we should approach and we should embrace this and treat now differently. This is the case that should be stressed in every disease, but as you can see, very different treatments pop up, and they slowly rose the survival, and today we expect the survival to be over 40 or even 50 years without even approaching the era of genetic treatment. Cystic fibrosis was also one of the first diseases that needed or implemented screening, and this was somewhere even before the arrow, because the first screening programs you will see started even in the 70s, but around 80s, regional, very robust screening programs started. And this was before the era of genetics, because just shortly after that, the CFTR gene was completely sequenced, which was a very important finding. And a lot of people at that time thought that having the gene and having a single gene disease would lead to genetic cure in a matter of years. But surprisingly, up to now, the genetic cure for cystic fibrosis is still not really at the reach of the hand, which it's also another very important lesson that we will discuss later on. There's been a lot of brainstorming and a lot of discussion and a lot of research that still cannot solve this puzzle, even though in the 80s, Francis Collins, one of the fathers of the Human Genome Project, thought, well, we have the cure at our hands. So as you see, this red line that depicts the survival in cystic fibrosis comes to a question, what's next? And actually in cystic fibrosis, the future is now. We have so many possibilities that are opening up, especially the possibility of modulation of the CFTR protein. We live in the era of small molecules. As we all know, the Kaleidos, Simkevi, Trikafta, and Kaftrio, how it will be named in the European Union, are just in front of our doors. And these are the drugs that are really effective and that really change the natural history of this disease. But we are all really much looking into the possibility of genetic treatment. And with all this put into account, you can see from the data of the American registry that the several cohorts that were already alluded to in the first talk have very difficult outcomes. And this is the presentation of lung function with one of the markers that we follow in all these patients. And as you can see from the lines on the top, the younger patients have excellent results, and the two more young cohorts don't even discriminate one from the other, and even the younger one has a hint to be even better than the cohort before, and the numbers that we can see are completely in the normal range. So the advancement of treatment in cystic fibrosis has really been huge. And not only if we consider the lung function, But the most important is gaining of weight, because this is one of the crucial parts, especially in the small children. And as you can see, the impact of early diagnosis in this disease is crucial. It is pretty much the same that all three of us are talking, that when we talk about the finding the diagnosis and early diagnosis and early treatment is crucial in several, nearly all diseases. And this is the depiction of patients that were diagnosed through newborn screening. This is the full line, and those that were found without the newborn screening. And you can see that patients that were diagnosed directly after birth had much, much better results. And the same, it's also true for other crucial markers of this disease, like the chronic infection with Pseudomonas aeruginosa, which is one of the 5 or 7 germs that we really screen for in cystic fibrosis, and that it has been linked to worse survivor. It's completely different in patients that were found through the newborn screening programs compared to those that did not have this possibility. And of course, all this also culminates in the different slope of lung function decline. And also this marker, even though not that much different, in very early, in very late patients, as you can see, because this is really one of the representations that it's very actual from this year. Even in very young patients in the late cohorts, with all the other treatments available, you can still see that those patients that were found, that were diagnosed with the national newborn screening projects, have better outcomes than those that get diagnosed later in life. When did all this start, and what were the beginnings? As you can see, already in the 70s, there were several projects around the world testing the albumin content in the meconium. All these screenings basically were metabolic screenings. They started in the US, but also Italy has a very prominent role in this research, especially the centers from Tuscany. In the 70s, there was a big advantage in the screening programs with phenylketonuria, when with the technique of immunoassay, the possibility was there to really test for nanogrammic and picogrammic quantities in metabolic samples like dried blood, and pretty much in parallel with phenylketonuria and problems with the thyroid. Also, the programs to start testing immunoreactive trypsinogen started, and this was a kind of a real start of a screening program in cystic fibrosis. Later on, very different two-stage screening programs were initiated, testing for IRT at 2 time points, and not only IRT, but also other metabolic components were sought, like pancreatitis-associated proteins, and still nowadays, there are screening programs that use this protein. Of course, with the evolvement of genetic treatment in the 90s, there started to be a combination of a metabolic and genetic testing with different components, either just one or several combined. And in 2000, there was first the possibility to have a basic metabolic screening just directly coupled to the genetic analysis. And even though our first thought would be that this is really the best way, that in this way we will really enhance the sensibility, but not only the sensibility, but also the specificity, it turns out that this kind of screening opens many new questions that we would not expect directly from the project. You can see how the newborn screening evolved throughout Europe. The large majority, nearly all countries in Europe are joined together in two CF communities. One, it's the scientific community that is the European Cystic Fibrosis Society. A part of the European Cystic Fibrosis Society, it's also the Newborn Screening Working Group that produces every year reports, and these are the slides from the last one. And the other one is it's composed by patients, is the CF Europe, and really these two organizations work hand in hand to assist patients. You can see that the screening programs vary across Europe. In 2000, there were just a couple of countries involved, but slowly the screening programs are moving throughout Europe, and many countries are already there. Some countries are seriously considering or have already pilots going on. So we really hope that in a couple of years, all these countries will turn into one shade of green, and so that every child born in Europe will have this possibility. The screening programs are not equal throughout Europe, and are not even equal inside any country. But you can see that there are still countries that completely screen in the metabolic way, like Portugal, but all the rest, in a way, includes the metabolic screening with some kind of also genetic testing. There is one, let's say, and like, for example, Ireland, when there is just a metabolic start and then analysis of a certain number of genes, which is very practical in a community that has a very much known and homogeneous population. On the other hand, we have another extreme, like for example, Norway, Denmark, and Poland, where the metabolic screening goes nearly directly to extended gene analysis, which raises many other questions that we will discuss later on. But once the result came out positive, meaning that an individual child has a positive newborn screening, this means that the child needs to be assessed in a CF center where a diagnosis will be definitely made. And we still believe that cystic fibrosis it's a clinical disease. So the real cornerstone of diagnosis still remains the sweat chloride. And on the basis of the measurement of sweat chloride, as you can see, the child can either go the three ways, depending on the result. But if the sweat chloride is low, basically the disease can be put out of our reasoning, which really should happen very, very rarely, because this produces false positive newborn screening results. This is one arm that really should be minimized. On the other side, of course, we have the complete confirmation of the disease, meaning that through some kind of a clinical testing and later on genetic confirmation, we have a clear idea, a clear confirmation that a baby in front of us is actually a patient. But in the meanwhile, we also have to realize that this kind of an approach, this kind of screening will generate other outcomes. We will find certain carriers, and even we will find certain babies that we still cannot say whether these are people with disease or just people with some kind of genetic variant, that we still cannot say whether this represents disease or not. Altogether, from the last...
Sorry, Dr. Kriveč, we only have a little bit more than 2 minutes left.
We will go fast then, because many things have already been said. As you see, altogether, it's about 70% of all patients in Europe that have been diagnosed that way. But we need to take into account that we will face these byproducts of screening. We will identify the carriers, which is possibly a problem in healthy children. We will have inconclusive diagnosis, which can produce a lot of anxiety and uncertainty, and we will have false positive results, which will lead to unnecessary anxiety and management. Altogether, we need to say that if we have a screening program in place, it is one of the byproducts, a very positive byproduct, that we will, with the passing of time, also drop the incidence of the disease. But altogether, besides having only positive results, we need to reconsider the Wilson and Younger criteria in the genomic age, and especially the field of uncertainty should be very much discussed and debated. What sorts of communication and what sort of program should minimize these issues. So thank you very much, and we're all looking into a very diverse and vast discussion.
Thank you very much, Dr. Kriveč. Unfortunately, we are running out of time, but we can fast answer the questions we got from the audience. The first one is, are there diseases that are screened at birth in all EU countries and some only in some? Is there this kind of information as a graphic presentation somewhere? I think you already presented a chart for cystic fibrosis, but maybe you can tell our the person that asked where to find a complete overview, if there is any.
Can I start?
Yes, of course.
Basically, all the rare diseases have been linked to several communities. One that is really trying to harmonize all of them is the European Reference Network. The European Reference Network is a project of the European Commission. It has a very robust web page. It is organized throughout diagnosis or groups of diseases, and a lot of information can be found there. The other one is the Orphanet, which is also another community that exposes all this. And there is also an international journal dedicated to screening. So a lot of this information can be found there. But I personally I'm not aware of a site that would combine all the possible screenings in different countries and regions. So I ask the others.
I don't think it exists, actually. I think it's you have to find information for each country and try to gather all the information. Actually, there are some diseases that are almost screened everywhere in Europe, but again, we don't have a common ground rule to screen some diseases. As far as I know, there are some differences between countries.
If I may just add on this topic, because I think it's hugely important and one of the crucial things for the future. Newborn screenings were originally developed for endocrine and metabolic diseases. And this was part of the, let's say, of this subspecialty. But nowadays, as we heard, for cystic fibrosis, for neurological diseases, for primary immune deficiencies, and there are several other diseases that are coming up. And actually, we do not have, not on a European level, but even within country, for example, in Slovenia, we do not have a group of specialists working just on neonatal screening for different subspecialties. So it's mainly focused, for example, on endocrine and metabolic diseases, but now the other subspecialties are coming. So I think that within country and on a European level, in the genomic area, there definitely should be some specialized groups focused on screening so that there would be kind of a harmonized development in this field.
Thank you very much. I'm really sorry for the other question, but we cannot go longer because they will cut us out of the Zoom line, the technician told me. I want to thank you all for your presentations and for this inspiring discussion. I think we should find another opportunity to discuss with the larger public and also with the media that could have a huge impact in bringing this issue to policymakers and to the larger public. Thank you very much for being at AS of 2020.
Thank you. Bye.
Thank you.
Thank you.